Thank you so much. Once again, thank you so much and welcome to our part 2 of the webinar series, Spine Care in the Personal Injury Patients. My name is Dr. Shadi Amin, and I am the Director of Public Relations and Business Development for Pacific Spine and Orthopedics, and I am the co-owner of Life and Health Chiropractic with locations in Inland Empire and Orange County. Pacific Spine Orthopedics has got 7 locations spanning from Northern California all the way to all through Inland Empire and Orange County and LA County. We're very excited today as we have a phenomenal group of doctors and attorneys with us to cover all aspects of spine care, concentrating on correct diagnoses, special diagnostic findings, the important options of having good treatment options for the patients. And we have the legal perspective from Attorney Ian Silverthorne to cover all aspects of what it means to represent patients with spinal injuries. First off, we have Dr. Andrew Thiry of Expert MRI with multiple locations in Northern and Southern California. Dr. Thiry is a graduate of Michigan State University and Northwestern, as well as Beaumont. He's a clinical instructor over at UCLA, and he has extensive experience in diagnostic, interventional, and therapeutic radiology. Then we're going to proceed from there to Dr. Kevin Trin, double board certification with anesthesiology and pain management. He is with Pacific Spine and Orthopedics, travels to multiple locations in Orange County as well as LA and Inland Empire. Dr. Trin is a graduate of UCLA, UCI, as well as Loma Linda University. Then we have Dr. Aline Najafi. Very excited that you got out of surgery, Doc. Thank you so much for joining us right now. And Dr. Najafi has board certification in neurological surgery. He's in multiple locations spanning from Northern California to Inland Empire as well as Orange County. The doctor is a graduate of Case Western Reserve University, and he's been in private practice since 2003 with extensive experience in spinal surgeries. Is going to be covering all aspects of spine surgery for us today. Last but not least, we have Attorney Ian Silverthorne. He has been a member of the $1 Million Advocates Forum and is named a super lawyer. He's been an attorney since 2012. However, he had extensive experience in law prior to becoming an attorney himself, working with some of the biggest names out there. And he has got major experience covering everything taken from food poisoning to dog bites to slip and fall accidents, motorcycle accidents, as well as motor vehicle accidents. With that all being said, I'm going to hand the floor to Dr. Andrew Thiry, and thank you so much again for joining us today.
Thank you, Shadi, and thank you, Audrey, and everyone else at Injury Institute for putting this together. I'm going to share my screen here. Is that okay if I share my screen? Okay, so as Shadi said, I'm the medical director at Expert MRI. What I wanted to do is go through a little bit about spinal imaging, starting with an introduction, or for some, maybe a review of, actually, for some of, this is, what they do every day. So definitely a review, but for others, just a quick overview of some of the important anatomy so that then we can talk about some pathology and how that shows up on imaging, specifically on MRI imaging. So just going through, we want to go through the spinal ligaments. I think a lot of people, when they talk about injuries, we're specifically talking about the discs or the facets or fractures. Oftentimes the ligaments are overlooked, and part of that's because they're difficult to see on an MRI. They're difficult to directly evaluate, but everyone knows when someone sprains their ankle, for example, they're actually injuring the ligaments of the ankle. You can also have bone injuries, cartilage injuries, but ligaments, often the knee, ankle, shoulder are the structures that get injured, in addition to tendons and the other supportive structures. So I want to go through the anatomy of that a little bit. The intervertebral discs, talking about acute and chronic disease and some of the nuances about how to differentiate those, and the effect of positioning on the spine as seen in different imaging positions. So flexion extension, upright weight bearing, and then we can talk about some of the cases that demonstrate these differences. So let's skip through this. So as you can see here, this is a cross-sectional or a sagittal image through the spine. On the left is anterior, on the right is posterior. And it shows, the anterior longitudinal ligament, posterior longitudinal ligament, these, support the spine and are often, injured in, for example, a seatbelt injury, fall injuries, other injuries where there's a high velocity change. So, and as well as the interspinal ligaments can be injured also. And then in the neck, you have my pointer's not working. So in the center of this image, this is with the posterior elements removed and it's looking anteriorly. So it's as if you're behind the patient, and it's showing the base of the skull as well as C1, C2, and C3. And you can see these ligaments at the craniocervical junction support the odontoid and keep the heavy skull, attached to the spine. And you can imagine, in a high velocity, especially, motor vehicle collision, the heavy skull often continues traveling forward, because it's heavier, and it can result in injuries of these ligaments, especially the cruciform ligament, the alar ligaments. And a good point here is that a lot of cervical spine imaging starts basically at C2, C3. So the sagittal goes through the craniocervical junction, but when you're talking about axial imaging, the axial imaging usually starts at C1, C2, or C2, C3, as well as the coronal imaging. Usually, actually, a lot of places don't do coronal imaging. So this area is often missed on a regular MRI of the spine, which which could be an issue when you have a patient that's been in a motor vehicle accident with a whiplash injury. This is showing these same ligaments, but from the top looking down with the skull removed. The top of the image is anterior and the bottom is posterior. So it's showing that transverse ligament there, the alar ligaments, cruciform ligaments. Those again can be injured, just like in anterior cruciate ligament or ACL can be injured in the knee, or lateral ligaments when you have a ankle injury. These ligaments are injured in in accidents. So very important to see these and evaluate them. This is showing another sagittal view, same sort of thing, anterior and posterior longitudinal ligaments, as well as the ligaments up at the craniocervical junction. I don't want to spend too much time on the anatomy, but this is just another thing to kind of remember is, moving from ligaments to disc, that discs are, have a small capillary supply to the periphery of the disc, and nutrients, oxygen, fluids diffuse into the disc. So if you have an interruption of those capillaries, you're depriving the disc, whether it be from atherosclerotic disease, smoking, things like that, or an acute injury where you're damaging those small vessels. You can have an interruption of that diffusion in those nutrients, and then you get things like disc desiccation, breakdown. So that can happen in the acute phase from an injury, or as a chronic degenerative change. If someone has a genetic predisposition to that, to small vessel disease, or has lifestyle factors like smoking, atherosclerotic disease, diet, lack of exercise that lead to damaging those small vessels. These are just a couple more representations of that, as well as in the center you have an MRI showing at L4, L5, which is towards the bottom of the image, the darker disc. So this darker disc is desiccated. There's an issue with the either the diffusion of nutrients on a chronic basis or on an acute basis. from an injury. So if you have an injury that disrupts those small vessels, then it can result in a similar appearance. So if you have a prior MRI from a year ago or year or two ago, you can make that determination in a better way to see. Hold on one sec. I'll be right back. Sorry. Sorry, somebody fired up a leaf blower. And when you have an injury to those vessels or to the disc, nerves actually, if you look at this image on the right, this is just showing that the nerves actually growing into the disc, which can increase the pain sensitivity, which contributes to discogenic pain. And this is just showing a disc protrusion, extending through an annular tear, annular fissure. And let's look at some cases here. Actually, let's talk about position first, because this is important. When you get an MRI of the lumbar spine, thoracic spine, cervical spine, they're done in the supine position, which is, if you look at this graph here, all the way to the left, and this is showing relative pressure on each, or on the, I think it's the L3, L4 disc level. So, 25% relative pressure at the L3, L4 disc in the far left here where the patient is supine. And then in different changing positions, you can see how the pressure is elevated, at that disc level. So, taking a patient that's standing up, bending over, the relative pressure is 150 to that 25 when the patient's supine. So when you're stressing the patient at different levels, you can uncover pathology related to the ligaments, instability, anteriolisthesis, retrolithesis, lateralisthesis, and that's really how we evaluate the ligaments, is secondarily through translation, oftentimes, again, standing up or flexing or extending. And some of these patients will have symptoms only when they're, in certain positions or weight bearing, as opposed to, their symptoms being relieved when they're lying down. So it really makes sense to image these patients when they're in the position that they're experiencing symptoms. So this is just showing a regular MRI, closed bore magnet. And then these are the open front where you can do some additional imaging. You sacrifice some resolution, but in certain situations, we make those determinations, all the time, with certain, with certain things outweighing resolution. For an MRI brain, you want the highest resolution, for example. You don't need to do positional imaging, but in a accident situation with the spine, it may be helpful. And this shows partially why that's important. Again, the recumbent, just the regular supine imaging on the left, and then on the right, you can see in the upright weight-bearing view that the discs are pronounced. The disc protrusions are more pronounced. And you can actually see how they're pressing on the cauda equina at the L1, L2 level. You can see that it's abutting the thoracic spine up in the lower thoracic spine, and then down at L4, L5, you're seeing a more pronounced anteriolisthesis of L4, L5 and compression of those traversing nerve roots. This is another case, similar story, where you have disease on the left here, and it looks abnormal, but it's much more accentuated once you, again, increase the pressure at that level and uncover some findings that you wouldn't have seen before. I mean, this patient now has a significant compression at L3, L4, as opposed to on the left here. Yeah, there's some, canal stenosis. There's a, significant protrusion, but it's not compressing the nerve roots. And this patient this patient will have significant symptoms, potentially even, cauda equina syndrome when they're upright weight bearing. And likely symptoms, at least in the acute phase, relieve somewhat when they're lying down. This is showing, recumbent on the left and then upright flexion and upright extension as we're moving to the right. And you can see how the findings are changed depending on, we're doing measurements for anterior, we're doing measurements for disc bulges. These measurements change when you're stressing the spine, if there's any damage to the ligaments. If the ligaments are intact and normal, we usually don't see much, if any, change on flexion extension. And I'm noticing that we're getting up on 20 minutes, on 2:20 here. So this is more of the same, showing the accentuation of disc protrusions when you extend the spine, which makes sense. This one on the left is upright. So if this patient was supine, these protrusions would likely be even a little bit smaller in size. But on the right, you can see that they're actually causing some significant central canal stenosis, and likely, these findings on the right correspond better with the patient's symptomology and history than you would get on a supine image. This is another thing that we can see, that we will see sometimes, is on a supine, we'll see a large disc. And in this case, this patient will go for surgery and they'll get a discectomy, potentially even a fusion. And if you don't, if you look at this image now on the right, this is an extension. So it's showing actually a disc bulge above, at the level above. And, the surgeon's going to want to know that, because they're going to want to include that in especially if they're doing a fusion, because, if you just fuse that level with the large disc on the left here, and you had pathology at the level above, that's going to now be, accentuated, because, pressure is distributed, at, 6 levels instead of 7 now. So that's really important from a pre-surgical standpoint. And some more of the same here, showing, the view on the right, the disc protrusions in extension. And then this is the last slide with patient images. This is showing, the importance of imaging at the craniocervical junction here, and including your axial images high up enough to include this area. I don't know how easy it is to project here, but you can see there's actually a fracture. If you look at the odontoid, this is sagittal view again, right at the craniocervical junction, the odontoid tip, there's a fracture. There's instability, there's fracture of the ligament, as well as abnormal signal in the upper cervical spine there, right at the craniocervical junction. This is a significant injury. There's instability here. And this was actually not described. A lot of radiologists will actually, and it's just part of our training and everything, that's sort of a blind spot, that area. We really focus on the disc in the cervical spine. And, when you're dealing with patients that have been in significant injuries, motor vehicle collisions, that's really, really unacceptable. You're going to miss a lot if that's the approach that you take. So, at Expert, we have a lot of those different, we take the approach of how do we uncover as much pathology as we can, because the worst situation is patient gets in an injury, has a significant injury, and then, the imaging doesn't correlate. So we really try to do everything we can to, have 1.5 and 3 Tesla closed MRIs, as well as these opens, so that we can do different imaging like that. So that's it for me. Thank you, Shadi.
Thank you so much, Dr. Theory. And now it's going to be Dr. Kevin Trin. Thank you so much, Doc.
Thank you everyone for joining us today, and also allowing me to take part in this great conference call. Let me just share my screen real quick.
Oh, Dr. Trin, it seems like you're on mute. Are you on mute? I cannot hear you.
I'm not on mute. Can you hear me now? Can you hear me now?
Is anyone else having difficulty hearing Dr. Trin?
Hello, can you hear me now?
Yes, Doc, it seems like you need to press unmute. I'm not sure if you're on unmute or not. It seems like they are having difficulty. Can't hear anything. One second.
I can hear you a little bit, Dr. Trin, but it seems like it's really far away and quiet, but I can hear a little bit, so I don't think you're on mute.
I'm on mute. He can hear me, but she can't hear me.
We do have a plan B. No worries whatsoever here. Apologize for the 2-second delay over here. Here you go, Dr. Trin. We're ready for you. Thank you. Can you all hear me? Wonderful. Apologize, technical difficulties over here. We've tested this before. And it all worked.
Can they see?
Yes.
Where do you?
You have to just click down and you're going to be sharing your.
So where am I?
We're on right here. First up.
Where's the screen?
You're on the screen and we're sharing right now currently. They're
I
watching.
need to go back to the other slides.
There you go.
All right, where am I? Hi, everybody. Can you guys hear me now? Okay, thank you very much, Dr. Theory, for such an informative talk. And thank you everyone for allowing me to be here and speak and enjoy this great conference call, okay? My name's Dr. Trin. I do pain medicine. Just real quick, so now that we covered chiropractic therapy as well as objective findings to MRI, so once a patient gets referred to my office for pain management evaluation, I just want to be, prior to recommending any interventional procedure, I just want to make sure that they try some conservative therapy, such a minimum of 6 weeks of physical therapy or chiropractic therapy. And once I do a complete exam, then I generally would recommend certain interventional procedure to try to get patients to live better. Some of the most common interventional pain procedures that I perform, or pain management in general perform, include cervical, thoracic, and lumbar spine epidurals. That includes interlaminar epidurals as well as transfemoral epidurals. We also perform facet injection, which subsequently can result in radiofrequency ablation. We also do sacroiliac joint injection, piriformis blocks, intradiscal provocative discography, as well as a spinal cord stimulator. Just in interest of time, I'm just going to be covering two of the most common procedures that most of you guys kind of see in terms of notes-wise what pain management do, which includes the epidurals as well as the facet injections. Then I'm going to finish up by discussing briefly about the spinal cord stimulator and what we generally do for that. So for the cervical epidural steroid injection, generally I recommend the epidural steroid injection if patient have number one, pain in the neck, with or without radicular symptoms down the arms. In addition, there should be some objective findings on the MRI which shows bulging disc, herniated disc, disc protrusion, or even disc extrusion. So for the cervical epidural steroid injection, the main point I wanted to express here, number one, is that we can approach the epidural either through the front end or the back end, and majority of the procedure is usually use the posterior approach. So the main thing I want to point here is that number one, that Although you may have some bulging disc or herniated disc or disc protrusion at different levels, whether it's C4, C5, C5, C6, C6, C7. In general pain management, doctor, we generally do the procedure done at the C7, T1 level. It's because of two main reasons. Number one is that at that level, the epidural space is is the biggest in terms of space-wise, so it's very safe. At any levels that are higher than that, the epidural space is very narrow, so therefore you have a extra or you have a increased opportunity or chance of complication, which includes an epidural wet tap. So basically what it means is that if we do when we get into epidural space, since the epidural is so tight, sometimes the needle can go a little bit too far, and that can result in a dural puncture. And oftentimes that can result in severe headaches for the patient, and that could probably result in a second epidural blood patch where we have to go in there and put the patient's own blood to kind of cover up the hole. So the medical literature recommends that we do the procedure at the C7, T1 level, although that you may have a bulging disc at C4, C5, C5, C6. With the epidural space, it's a very narrow space. Therefore, even if I do the injection at the level C7, T1, you'll get the good spread up into that level to provide patient pain relief. This is an important point because, I had one case where, and actually, sorry about that. Sorry. So this is a picture of a epidural that I did yesterday, actually. So as you can see, this is a C7 T1 space. This is the needle coming into the epidural space, this space. And this is the contrast, just highlighting that, make sure that I'm in the epidural space. Again, okay. So this is a cervical facet pain distribution. So basically what this is when patients have pain in the neck resulting from joint irritation that are in the neck. The facet joint, this just shows you the general distribution of the pain whenever a patient has facet pain. So if they have facet pain at the level C4, C3, C4, this is the general area. So sometimes you get a C5, C6 level here, the patient would complain of neck pain. It's going down my shoulder and between my shoulder blade area. So this is a schematic picture of the facet from the side view. So each facet here, as you can see here, let's say this is a facet, and that each facet joint is innervated by a nerve, one on top, one on the bottom. So when a patient has a cervical facet, usually the patient has axial neck pain, and on palpation, usually they have a pain on palpation, which is on the left side or the right side, depending on the level of pain. The couple of points about this is that number one, with each facet joint, there's two nerves that innervate the joints, one on top and one on the bottom. And when we do the injection for the facet joint, you can have an option between either putting medication into the joint, or you can block the nerves that are innervating the joint itself. With a lot of literature indicating that there's more benefit from injection around the nerve area. So majority of us pain doctors, when we do facet nerve block, we actually blocking the nerves that are going to the joints, okay? The main point I want to bring out about the facet joint pain is that for diagnosis of facet joint, we really generally don't use MRI as a tool for diagnosis facet. So therefore, sometimes when you see a patient and you see that the pain doctors or I'm recommending a facet joint nerve block, yet the MRI may be completely negative, benign. So there's no facet pathology. There's no anything that indicates facet mediated pain. So the point is you may have a negative MRI and still have facet joint pain. So so just to reemphasize, you may have a completely normal MRI and people still have facet mediated pain. The only way that you can really diagnose facet joint pain would be to do a diagnostic block. So basically, if I think these joints are causing your pain and I block the nerves and your pain goes away, they help me isolate and pinpoint the reason why you're having pain. So that's only the true way to diagnose cervical or lumbar facet mediated pain. So this is the injection I did yesterday, where this is the patient's jaw. This is as you can see, let me just go back real quick. Go back. So the nerve is sitting right at the pedicle here on the east side of the neck. So it's right in the middle of the bone. So with the injections, here's the middle of the bone, and the nerve is sitting right at the spot. Okay, so what this is basically, the C5, C6 facet joint is right in this area. So the nerve is one on top, one on the bottom, and as you can see, my needle is going right into the nerve area. So this is a schematic picture of a lateral view of the epidural for the lower back. So this is called a lumbar transfemoral epidural injection under fluoroscopy. So what this shows is that this is vertebral body, this is the disc, and when you have a herniated disc, the disc starts sticking out in the back here, and what that does is cause irritation, inflammation around the nerve. So to provide relief, what we do is we introduce our needle right into this area, and what we want to do is we want to put this area, we'll give it a little anti-inflammatory, some local anesthetics, some natural plant-based, and some cortisone, and I'll speak about that in a little bit further down the talk. So this is just a AP view of the picture. This is the needle coming in right here. This is where the nerve root is coming out at the L5S1 level. As you can see, this is the disc at the L5S1, and this darkness that you see is just the highlighting of the nerve root. Once we inject the contrast dye, they make sure we're in the right spot. So this is a schematic view of lumbar facet medial pain. So what's important about this slide is that, number one, it shows that facet pain can, most of the time, it's actually just axial, but sometimes patient can have a referred pain where actually patient feel it in the thighs and as far as even down the leg area. And I've seen that where basically what patients have, basically they come in, they have back pain, the MRI showed there's no disc herniation or disc protrusion, but they still complain of pain down the legs. And sometimes when we do a facet nerve block, and sometimes that can alleviate that based on this. So just to show the anatomy, the lumbar facet, and again, same thing. Each facet, you can see here, is innervated by one nerve on top, one nerve on bottom. So what that allows us to do is that if we want to block we think this joint is causing pain, all we do is just block one nerve above it, one nerve below that. And I'll show that. So this is a fluoroscopic image of a procedure I performed yesterday. This patient had a lot of back pain on the right side, and I suspected the patient had pain both at the L4 or 5 facet, which is right here, and the L5S1 joint, which is right here. So what I do is I put the needle right where the nerve I think is sitting, that innervates the two joints. Again, if this is the joint I'm concerned about, I put a needle one on top and one on bottom. This is where the nerve is sitting. It's called the median branch nerve. This is the nerve that innervates the facet joint. And again, since this joint is, I suspect the L4 or 5 facet joints are irritated, I also put one needle up here where I'm blocking this nerve, because this nerve also sends fibers down here to send signals to your brain. So what's important about the cervical and the lumbar facet is that when we do these blocks, the main reason why we do these blocks is really for diagnosis-wise. If I think these joints are causing the pain and I block the nerve and the pain goes away, that helps me identify and pinpoint the reason why you're having pain. Unfortunately for this block, sometimes patients get better. They move on. Unfortunately for some people, the block is only very temporary. Maybe 1 day, maybe 2 days, maybe 3 days. It's kind of like going to the dentist. When you put a local anesthetic into the area, unfortunately, it wears off. So for those that the medication wears off, our recommendation for long-term relief would be a radio frequency ablation, RF, and you guys have heard of those terms. So basically what that means is that I know the nerve is sitting in this area, and in order for me to give patient long-term pain relief, we use a specialized needle where the tip, I might be able to connect it to a wire. And what allows me to do is at the tip, I can heat it up to 80 degrees Celsius. By heating up the tip of the needle, what allows me to do is make these nerves not function anymore. Main thing is that these nerves, they only do one thing. They just send pain signal from the back to your brain. It doesn't do much else. So therefore, if we are able to heat it up and make the nerve not work anymore, in the long term, it will give patient pain relief for a longer period of time, anywhere from 6 months to 2 years. So that's what the term radio frequency ablation or RF means. So that's what that means. So we just heat up the tip, make the nerve not work anymore, and hopefully it'll give them long-term pain relief. And lastly, I just want to touch a little bit about spinal cord stimulation. So spinal cord stimulation basically is to make it simplify, it's basically the pacemaker of pain. So how it works is basically by putting some electrical leads into the spine area, What it allows you to do is just send out electrical impulses. By doing that, it allows you to block the pain signals coming from the back, going up to your brain. So by blocking the signal, then you feel less pain. The analogy with this would be, let's say if you bang your knee into a couch or something like that, and you rub it really quick. The reason why you're rubbing it really quick is that rapid rubbing action is actually suppressing the pain that you're actually experiencing in the knee. So with a spinal cord stimulation, the same analogy. So when you have a lot of pain in the back and it's sending signals up to the brain, but if you put some electrical wires here and you just send a whole bunch of high frequency stimulation to the area, what it does is it suppresses the pain so that for the patient or the client feels less pain. So typically for patients are candidates for spinal cord stimulators include like patients who've had back surgery and still have persistent pain, or either number two, but patients who have persistent back pain with a positive objective findings of MRI, such as bulging disc, herniated disc, or something like that. Yet when the patient sees the surgeon, surgeon said patient's not a surgical candidate. So this is a good way to try to manage the patient pain. Another group of patients that would benefit with this would be patients who have objective findings on MRI, who have been evaluated by back surgeon, and yet the patient is, for some reasons, they're very reluctant. It does not want to have the surgery, and this would be another alternative for the client or the patient, so they can try to manage their pain. And the last indication for this type of for spinal cord stimulation would be any type of pain in extremities, which includes arms or legs, which have any type of nerve type of pain. In particular, patients who have had injury to the arm or the leg from a traumatic event or from an accident, that results in nerve injury. And one condition would be something like complex regional pain syndrome of the arms or the legs. So this is just a picture of the spinal cord stimulation. So with the spinal cord stimulator, excuse me, it's a two-step process. And the advantage of this procedure is that, number one, the patient gets to try this out before we actually implant this into the patient's body. So with the first step, basically it's just a needle in the skin where we put it into the epidural space. Once we get into the epidural space, we guide the wire up to the epidural space, and we remove the needle. Once we remove the needle, all we do is just tape it down and we connect to the external source. It allows the patient to actually try this out for a week, excuse me, and see if it helps them or not. So the advantage of this procedure is that, for patients that are so reluctant to have any surgery, at least this procedure, you're allowed to kind of try it out first, see if you like it or not. Regardless, you have to come back in a week for me to pull the wires out. But at least during that time, patients get to actually try, see how beneficial it is for them. So if they like it and and it gives them a good pain relief, then what we do is ultimately we have the patient have it put in permanently. And our Dr. Najafi, who's going to be speaking shortly, he's going to be addressing that. Maybe he'll address some of that, but basically he can put it in the stimulator permanently, so that gives patient pain relief. So, okay. So I just want to end up real brief, just discussing, one of the main things and unique thing about our practice, that what am I being injected into the spine when I do some of these procedures? The usual cocktail is usually local anesthetic, some steroid, but in my practice, I know that we are aware that some patients are very adamant about not getting steroids, whether they're diabetic, they're afraid the sugar goes up, or they're just thinking about having steroid injected in the body. What we do is we provide an alternative where we provide injection into the spine. We use Serapin. Serapin is a natural plant-based medication. It's an FDA approved medication for us to inject for treatment of pain. And so for patients that do not wish to have any type of steroid injected, then oftentimes we'll provide an alternative where we can give them Serapin in place for pain relief. So Serapin, this is showing that Serapin is a biological medicine that's derived from a pitcher plant. Okay. I think that's it for me. So if all these modalities don't help, then we send our patient to see Dr. Najafi, who's going to be speaking next. Okay. So he'll discuss some of the surgical options available for the patient. Dr. Najafi.
Okay, everybody hear me? All right, try to share my screen.
I do realize some of you are posting some questions. We will address these at the end. Thank you.
Did everybody see the screen yet, or?
Yes, go for it.
Shadi, is my screen up for presentation?
Yes, Doc, we just need to just click on that screen by itself. I can come and take a look at it for you.
Okay, yeah, do that, please.
Sure. There we go, you got it. Perfect.
Oh, we're on, okay.
Yes, you're on, absolutely.
Great, well, thanks for the opportunity for me to talk about the surgical aspect of the spine. And I'm Ali Najafi, I'm a neurosurgeon, board certified, and partner with Dr. Trent. So I do give surgical opinions and consultations for patients who failed non-surgical therapy, such as injections, medications, and chiropractic treatment, and so on. But I have to say that my rate of patients that would need surgery, that would go ahead with surgery or benefit surgery, is 1 out of 10 or 20 patients that I see that I do offer them surgery. I explain to them the pathophysiology of their pain or their loss of their function, and talk about options overall, which they have had some by the pain management specialist and the chiropractor. And when it comes to surgery, obviously nobody wants to have surgery just to have surgery. So I have to explain to the patients the indications, the benefits, the risks, and at the end of the day, usually, like as I said, 1 out of 10 or 20 patients that I see would want to undergo surgery, and that everybody doesn't really benefit surgery. So, but I don't mind seeing patients for a consultation to figure out where the pain's coming from and what other modalities are there to treat their symptoms, and as well as the causation, which is very important in medical legal issues. So today I just wanted to talk about the lumbar spine because we have limited time. So what a low back pain is, what a disc herniation is, what a lumbar stenosis is. Here's an MRI with one disc that's degenerated, it's not herniated, and that's something we'll talk about later about a discogenic low back pain. This picture shows you the actual anatomy, what a normal disc look like up above. And when they become degenerated, they have less water hydration and some tear. And then there's a bulge here that develops. So that's a disc bulge, if you will. When the disc comes out, here's the herniation. And in this case, you have a combination of degenerative changes with the loss of disc height. And at that point, what the body tries to do is to autofuse that disc. And the body then develops osteophytes to try to bridge the gap. And that's probably why a lot of the older patients don't have a whole lot of back pain, because their discs are pretty much autofused. This is an example of a normal disc up top versus a degenerative disc with a bulge. This is a fragment that came out of the disc, so disc herniation. And this is a slip vertebrae and condition that we'll talk later, causing back pain. So, you know, everybody gets old, and if you MRI people range from, you know, 30, 40 to 60 or 70, there's pretty much average of 50 to 70% of patients who would have degenerative changes in their spine if you MRI them and if they were asymptomatic. So just having degenerative changes doesn't mean that you're going to have symptoms. So obviously something triggers the symptoms, whether it's trauma or infection or malignancy or so on. Then these patients become symptomatic and seek medical attention. So pretty much 95% of back pain is just acute low back pain, which is musculoskeletal. Could be from motor vehicle accident or slip and fall. And obviously I don't see those patients because the treatment's all non-surgical, pretty much NSAIDs, education of how to properly use your back or your spine, and then therapy as well as chiropractic treatments, and rarely then the acute strain would require additional treatment. So I usually, everybody knows that bed rest for an acute back pain is really not that helpful, but mainly medications, cold and heat, maybe some bracing and some oral steroids should take care of the problem. And if it keeps going, then that's when pain management comes in play. Everybody gets an MRI, but usually it's best to wait a few weeks, make sure that the pain is not musculoskeletal, and if it continues, then obviously MRI is the standard of the gold standard. X-rays, you don't really get a whole lot from it. CT scans, a lot of radiation. Sometimes a bone stack scan may be helpful in special cases. So here's a different list of the cause of back pain. Most common is your herniated disc, and you could have a discogenic pain, or facets may be causing you the pain, and the rest is pretty much obvious. If you have a compression fracture or spondylolisthesis or stenosis, they're pretty obvious cause of pain. Here's an example of an acute disc herniation. You can see on the sagittal, on the axial. This is pretty much a surgical case and if patient has back and leg pain. So although some people might try an injection here and there, but clearly if this patient has radiculopathy, numbness, weakness, and back pain, I would rather see this patient first before we would try anything else to give them the options. Here's something that we all talked about, the radicular symptoms, dermatomal patterns, numbness, weakness, and the Ct syndrome is fairly rare, but it does happen in the L1, L2 area, or L2, L3. This is another artist depiction of what a protrusion is, extrusion subannular and extrusion through the annulus, and it's sequestration. So gives you the idea of what types of disc herniations we deal with. Pretty much rest, NSAIDs, chiropractic treatment, mineral dose pack. That would be the first few weeks, unless somebody has a clear neurological deficit, acute foot drop or Ct syndrome. I think surgery would be definitely indicated at first. So for a disc herniation, the standard of care is a microdiscectomy. Some surgeons use an endoscopically assisted microdiscectomy, which it's pretty much operator dependent. Laser surgery is a big mystery. Still don't know what some of these advertisements are for. And the bottom line is that you still have to go in there, you have to decompress the nerve. That means you have to remove some of the disc material. Here's an artist's depiction of retracting the nerve, and here's a disc bulge that were taken out. And here's again the nerve root going up and down and retracting that nerve. And then you do see the disc bulge here, where we make a small incision and decompress the nerve by removing some or most of the disc. Let's move on to other causes of the back pain, the discogenic low back pain, as well as the stenosis or spondylolisthesis. This case is an older patient who has a lot of the degenerative disc disease in addition to ossified formation. The disc below has a spondy with severe disc height loss. So this is a combination of the two that can be treated surgically. As far as the stenosis is concerned, causing symptoms, as we get older, everybody pretty much going to have some sort of a stenosis, whether it's mild, moderate, and majority of patients are fairly asymptomatic till the later years in life. But definitely an incident such as a fall or a force of due to motor vehicle accident could then make this pre-existing degenerative changes or stenosis become symptomatic. So that's a question they always ask me in depositions. So doctor, this was a degenerative change, so therefore the accident had nothing to do with it. Here's pretty much what a normal spinal canal would look like. Now, if you have a congenital short pedicles, here the pedicles are very short, you already don't have a whole lot of room in the spinal canal. So these patients with short pedicles definitely are at a higher risk to become symptomatic sooner than later in life. And if you have degenerative changes here, that means the facets are overgrowing and so are the ligaments. And on top of that, you have a disc herniation. So you have a circumferential stenosis that can cause both back and leg pain that would need surgical treatment. So we talked about the neurogenic claudications, intractable back pain, and failure of conservative care. And the standard of care for just a simple stenosis is just laminectomy, where we remove the ligaments, we remove most of the lamina, try to not to violate the joints or the facets. And most patients with neurogenic claudications improve significantly. There's no need to do a fusion or do more aggressive surgery in that case. And here's an example of where we undermine the facets and we remove the ligaments in the foramina to do a foraminotomy. As far as the spondylolisthesis is concerned, which means the forward displacement of one vertebrae over the other, is definitely something, it's a source of a pain. And if you have a spondylolisthesis, which means that you parse interarticularis where the two vertebrae connect together, has weakened congenitally or due to multiple injuries as a younger patient to then become weak, and at some point they break and the patients become symptomatic, whether it's a fall, as a traumatic injury, then the spondylolisthesis may become symptomatic due to trauma. So this is a pre-existing condition which then becomes symptomatic due to, for example, a motor vehicle accident. Here's an example of a spondylolisthesis of L5S1. Here's a parse defect that one could appreciate at this level. And pretty much the treatment is the same: epidural injections, physical therapy, weight loss. And I've had patients who live with their spondy for years, but when they get older, like 40s and 50s, when the spondy gets worse and the stenosis is worse, they become symptomatic. And at that point, they need surgical treatment. So indications, as I said, is persistent pain, progressive deformity, motor deficits, neurological deficits, then we would consider surgery. And there are different ways to do this operation, either to the front or to the back, whether fuse the disc itself or just put screws to the side. Here is just an in situ fusion, which means you just lay bone, but that's pretty much outdated nowadays. Here is just putting pedicle screws without addressing the disc, which the fusion rate is not as good as if you were doing interbody, where you restore disc height and you realign the vertebrae. So this is a PLIF or TLIF, which means going either through one side or both sides to then remove the disc, restore disc height, and do a fusion. Another way to do this operation is going through the front. A stands for anterior, so you get a vascular surgeon to do the exposure, and you're able to have a good size exposure to the disc where you can replace the disc with spacers and sometimes we back these cases out with pedicle screws to the back to make sure that the construct is very solid. So that will be the treatment for the spondy. As far as the discogenic back pain goes, that's something that could happen at any age. I've had patients in their 20s, sometimes 18 or 19, that suffer from discogenic back pain. And that's something that, here's an example of degenerative disc, possibly annular tear. The hydration has changed. The disc bulge is very minimal, but you see the tear here on the left. And these patients who have discogenic pain, the pathophysiology is just the annular tear creates, once pressures on the disc, different proteins and inflammatory changes would cause the irritation of the nerve endings of the disc and cause back pain. There is no actual mechanical compression that exists. So that is something that's hard to diagnose. You want to make sure that other sources of the pain are eliminated. Let's say somebody comes and does the facet injection, the patient doesn't get better. Epidural, the symptoms improve, but then it doesn't last long. And you have the symptoms of pretty much deep-seated midline pain, and it's aggravated by bending and lifting. It doesn't really get better with rest, and you send them to therapy, they actually get worse because it just aggravates the disc itself. Sometimes we do what's called a discogram, where we put a needle in the disc and we try to change the pressure of the disc and to see if we can cause concordant pain, as well as getting a CT scan afterwards to look at the degree of tear when the dye has been put in the disc. If it leaks out, that means there's tear of the disc, and there are different ways to rate that. And a significant tear of the disc with concordant pain is pretty much standard of positive discogram with somebody with a discogenic pain. So the treatment for that is you have to address the disc, whether it's a fusion or disc replacement. One would determine based on the patient's age and the anatomy and multi-level degenerative changes that happens of the adjacent segments. So I'm a proponent of disc replacement, both in the lumbar and cervical spine, when and if it's indicated. Not everyone benefits it, because if you have somebody who has a lot of facet arthropathy, and if you're putting an artificial disc, you're asking for an already arthritic disc to move. So then they, have facet pain, and you have to deal with that. But in a healthy young person without facet arthropathy, without split vertebrae, and a good sized disc height, I think the artificial discs, both in the cervical and lumbar spines, are superior to fusion. So here an example of artificial disc. This is a Charité at L5S1. Here's a Pro disc at 4.5. And here's a picture of an artificial disc. That's it, I'm done.
Thank you very much, Doctor. So appreciate you. Thank you. And now we've got Attorney Ian Silverthorne. Thank you so much, Dr. Najafi.
Sure.
Hi, can you hear me?
Yes.
Okay. Thank you, Dr. Najafi, Dr. Trin, and Dr. Thierry, and thank you, Maria and Injury Institute, for having me. I do not have a slide presentation. I've been asked to give the attorney's perspective on everything that was just said. And right off the bat, I want to remind everybody just as a brief intro, my background is I grew up in Maine. I came out to California when I was 19. I went to Chapman Law School, graduated and passed the bar in 2012, and I've been practicing on my own exclusively in plaintiff's personal injury since. So my advice and feedback is based on that level of experience. So my philosophy is I really like to own my role as an attorney. And I think plaintiffs' attorneys really should do that. And that's the job of making sure that there's a recovery for our clients, making sure that the doctors get paid, making sure that our clients get compensation, making sure that we are well-financed to go to litigation if need be, and never needing to cut corners and accept a smaller than fair settlement because we're not prepared for handling a case properly. So as I've been practicing, I've developed procedures and thoughts that lead to just efficiently representing clients. With regards to soft tissue spine injuries, I think it's important as an attorney to remember that every single case that can develop to require the end of surgical intervention can simply start as a standard whiplash case. It can start as basic neck pain. And as conservative treatments drop off in their effectiveness and the case builds, the role of an attorney becomes more and more important because we need to find out what the envelope is of the case that we're dealing with and what the size of our client's damages are, and then figure out, is the available envelope of insurance proceeds going to cover that, those damages. I have litigated soft tissue cases involving spine injuries, and in my humble opinion, moving from doing the complete repertoire of conservative first treatment all the way through surgical recommendation, if that's necessary, is extremely important. My clients with whiplash injuries typically start out with chiropractic treatment. And if that is not effective in treating the acute injury, then they move on to physical therapy and pain management, and then to surgical intervention. I believe in having a medical doctor guide that process and obtaining an MRI so you know what's really going on with your client's injuries. Pain management can be very complex, and sometimes it can be difficult to explain to your client. I personally have had an injection in my lumbar spine, and I think it's a great procedure, and so I can explain it to my clients from that perspective. But as an attorney, leave the medicine and the medical explanations to the doctors. Your job is to make sure your client understands that this is an intervention that could stop them from a permanent change in their body. And then if it does get more complex, if that doesn't work, then again, leave the medical explanation for surgical procedures in the hands of the doctors. We have enough to do. We have enough to do in ensuring that our clients get a recovery. So make sure you are working with the right doctors on a case that could become surgical. Make sure you're dealing with doctors that have experience in treating automotive whiplash and treating the symptoms that come with automotive whiplash or similar cases. So some experience-based wisdom in my relatively medium-length career as an attorney. Remember your role as an attorney. We are not doctors. We are not chiropractors. We are not physical therapists. We are not radiologists. Treat a doctor in their opinion with respect. And I would be saying that even if I was not invited onto this webinar. It's a philosophy. There's enough to be done in focusing on what we should be doing. Attack health insurance liens and any other liens that are out there right away. Prepare things so you know what you're looking at in the end. You might be looking at an ERISA plan entitled to 100% reimbursement. You're going to want to start the negotiations with them before the case continues, so they understand that they're going to have to deal with you if they expect to get any recovery. Never, ever, in my humble opinion, try to build a case. There's no reason to do it. Unfortunately, in the plaintiff's PI profession, I have heard of many instances where attorneys base the treatment on the size of the policy, and they base the treatment on the size of the accident, and they think that getting some doctor somewhere to write some report is going to be some magic ticket. That's a short-lived philosophy in practice management at best. It's unethical, and at the end of the day, we as lawyers need to be able to look ourselves in the mirror. You know, and I took down some notes here, but it doesn't matter if the defendant is a serial killer and the accident could be viewed from space. If your client is healed, wrap it up, get them their recovery. Something I learned early on is find out what your client's injuries are, but don't let them download to you as the lawyer all of the intricacies of the pain that they're feeling. I had an experience with a client where they kept telling me about issues they were having with their spine and pain and describing this in incredible detail. And I had a case manager taking down notes. And then the doctor calls me and said, you didn't mention it at all. Client thought that by telling me as their lawyer, it was the same thing as explaining that to the doctor. So I tend to pump the brakes with that and say, hey, you need to take some notes. You need to get this to your treating doctor. It's very important that this goes into your medical records. So we have evidence, if this goes to trial, that you had these injuries. My humble opinion, don't be afraid of health insurance. I think a lot of attorneys try to avoid health insurance and only go with lien-based treatment. I've never been afraid of health insurance, and there are liens, but chances are pretty good that the insurance company might have valued the medical charges as though it was health insurance involved anyway. Get the med pay. If there's med pay, get it paid out. Get it paid directly to the doctors. Try to get out of that path. It helps move things along, and it can really help establish the value of the medical services if this case goes into litigation and you've got to fight with an expert on the defense side who's trying to assign value to CPT codes. You can point out the fact that, well, an insurance company already paid MedPay here and they already valued these services much higher than you are doing here. So how do you respond to that? Treat adjusters with respect. Sometimes I will make a joke with an adjuster. I'll say, oh man, I guess this case is not going to get me my condo in Monte Carlo. And they appreciate that. They appreciate the idea that it doesn't have to be adversarial every time you have a discussion with them. Which leads me to my next point. Don't roll over on a lowball settlement when you know the value is there. Just simply tell them directly, it's not going to work. I'm going to relay your offer because it's my ethical duty, but this is not going to work. And a lot of times new attorneys I've heard are very intimidated by filing a lawsuit and beginning litigation. Just file a form complaint. There's no need to write out the drama and just file a form complaint. Total investment, $550, get it served, do discovery, let the defense see you're not hiding the ball, and your offers will go up. And they'll learn that this is the way you manage your client's cases. Let's see. Make a decision as early as possible on whether or not a case is good for trial, but treat every case as though it is. The old phrase, you want peace, prepare for war. If you want a good settlement, prepare for trial. Never beg for mediation. Let the defense get their discovery out of the way, and that will come naturally. If you're a plaintiff's attorney and you are, and your client has MedPay on their auto policy, don't take a fee of it. I've heard of this happening with very, very, very limited attorneys. Don't, just my humble opinion, don't take a fee on the MedPay. And don't respond to garbage in litigation. The best response that I've come up with to a defense attorney threatening to depose all 13 of the witnesses to a dog bite and propounding way more discovery, as he put it, was, okay. Allowing somebody to do something and not opposing them doing it is typically the fastest way to cut to the chase, because then they realize they sound like idiots. If your enemy being the defense attorney, is making a mistake, don't interrupt them. I had a great experience with this where I had a defense attorney on a wrongful death food poisoning case who was just, liability was clear. It ended up being a very large resolution, but I had a difficult situation with my client who was on the verge of dying. And he was threatening a big motion to shut everything down. And I said, all right. And I let him make it. And in the process, he sent me a declaration by the manager of the restaurant in which he said that under no time during his management of the restaurant and training of the employees had he ever made any sort of food safety mistake. The inspector's reports were all erroneous and lies, and there were literally 142 violations. And everything was just incorrect. It was a total fabrication. The problem was that the defense attorney failed to notice was that this same manager was 2 corporate shieldings away from being the president of a real estate investment trust for his family. So the restaurant was kind of a hobby. And so all I did was doe him in personally, because in California, a corporate officer who is even aware of tortious conduct can be held personally liable. And I got 3 phone calls from the defense attorney, one explaining corporate shield, one of them threatening with a malicious prosecution lawsuit, and the third one about 3 days later telling me that was some sharp lawyering. And we very soon after went to mediation and resolved that for a confidential 7-figure sum. So if you're litigating a soft tissue spine case, you're going to get a lot of flack in terms of medical necessity, in terms of severity of the accident. You know, there's barely a scratch here. It doesn't matter. It doesn't matter if something's medically necessary and you have doctors that have performed the treatment and can come in and testify to that. That's all that matters. You're going to get a lot of flack. Ignore it. Move forward and get a good result for your client. So that's all I've got. Hope that was useful.
Wonderful. Thank you so much, Ian. Really, really appreciate it. If anybody has any questions, you can basically type it in for us right now. Once again, thank you to everybody, all the panelists, all the doctors, and injury